So, all right. And I want to introduce, so I've introduced myself. I'm Director of Workshops here at ResDAC. I've been working with Medicare data for 15, 20 years. And then we're really lucky to have Jia Jung with us as well. She's a professor at George Mason University. I think she was in graduate school at the University of Minnesota when Part D was first coming online. So she was one of the initial people to get to know the data when the data was first coming out. And she's used it extensively since then. Medicare Advantage, she has also been working with. And she's going to have some great segments and share the research projects that she's done. And then we also have Becky Vick, who will be presenting today and tomorrow. And she is a ResDAC, an analyst here at ResDAC. She has a lot of large data experience. She's worked at the Minnesota Population Center here at the university. She's also worked in the healthcare industry and their Medicare Advantage line of business. So, and then she's worked at ResDAC now for the last 3 years. So she should, she's going to have a lot of good information to share with you as well. And I'd like to get to know who is here and help you guys get to know who is here. So we have a poll that I'm going to run. It's just gonna, where are you? What kind of organization do you work for? What kind of research are you doing? How familiar are you? How familiar are you with the Part D data? So I'm just gonna pop that up, give you a couple minutes to answer that, or a minute maybe. Can everyone see the poll? I'll give just a few more seconds for everyone to finish up. Thank you for sharing the link. All right. I think we will end the poll so you can see the results. So we have, this is not unusual for our workshops. We have primarily academic researchers, but we also have a good number of people from for-profit settings and government and nonprofit. So we kind of cover all sectors. You can use this data for research in any sector that you're in. And then you could choose more than one of these, what your research interests are. Most people are health services research or healthcare administration, but we do have some economic folks and clinical research, public health, pharmacy. All of these things are, all of these fields have questions that are answerable with the Part D data. So you're in the right place. Oops, excuse me. And then, how familiar are you with the Part D data? So some people are coming at this fresh, and we try to design our workshops so that we can give you good background information so that you have what you need to go forward. Some people say, I know about the program, I really need to know more about the data and how to use it. And so that's another way that these workshops are primarily what we're designed for, is helping people use the research data. And then luckily some of you have helped someone close to you navigate the program. And this is a really good way to learn, or to, have a new way of thinking about how these data get generated. Obviously there's people behind them, but understanding the choices that Medicare beneficiaries are facing when they're trying to choose a Part D plan, for example, or, understanding how their benefits are working, how their co-insurance and co-payments. It's really useful to have that kind of information. So I would encourage you, if you know someone, you could just even ask them about, how did you choose your Part D plan? And then we have you used Medicare D data for research before? A lot of people have no experience at all. Some people have used other prescription drug event data. So you might find that this will be similar in some ways, different in some ways. Some people have used it and then use it alone or in combination with others, and some people have used it alone. So I'm happy that you're here. A lot of times with our workshops, you get something that you maybe didn't know before, even if you've already been using the data. Sometimes it's really helpful to have used the data to kind of have a frame to hang some of the stuff we're going to talk about on. But if you're coming in completely new, that's all right too. So that is all of you guys. I'm very happy to have you here. One of the things I love about these workshops is that we get people, you're an expert in pharmacy benefits and you're here to learn about the data, and we get to learn from you as well as you talk. So with that, I'm going to move into the content of the workshop. We'll talk about just a very brief introduction to the Part D program and what we hope to accomplish with the workshop today. And it's really helpful to understand the original structure of Medicare when you're talking about Part D, to kind of understand some of the underlying pieces. So the Medicare program has been around since 1966, and it was originally for elderly beneficiaries. Pretty quickly added coverage for people who were unable to work and qualified for Social Security Administration disability benefits. And then also people with end-stage renal disease, relatively recently, people with ALS also can get Medicare coverage. So the primary population that's covered by Medicare are the elderly, those 65 and older. And with Medicare, they receive Part A as an entitlement. This is hospital insurance, which also covers post-acute care. So if you're out of the hospital and you need skilled nursing or home health or hospice, that's all covered under Part A. Part B, you pay a premium to buy into, but most beneficiaries do it. It's subsidized, and that will cover outpatient and professional services, physicians, other care providers, durable medical equipment. Note that some drugs are covered under the Part B program, primarily things that you might receive in an outpatient setting, something that you're not necessarily administering to yourself. Although if there's maybe an oral equivalent of a chemotherapy drug, for example, that could be covered under Part B. So there is a link at the bottom of this slide that can give you more information about what's in Part B versus Part D. But other than those drugs, prescription drugs were not traditionally covered by Medicare. In the 80s, managed care alternative was added. So the way that this operated is that private plans would administer the A and B benefit, and the Medicare program would pay the plan per beneficiary per month payment, and then the plan was in charge of, keeping their costs under that payment. And so that's known as Medicare Part C or Medicare Advantage, and it's not separate from A and B. This becomes important if you're trying to measure enrollment in the Medicare program, because you can measure whether they're enrolled in Part A and Part B, and then you also have to do a separate toggle to know whether they're enrolled in Part C. And Becky will talk a little bit more about the master beneficiary summary file, which is where you might find information on how people are enrolled in the Medicare program, which parts are they enrolled in any given month. And then in 2006, Part D came along. So this was implemented in 2006, but it was enacted in the MMA, the Medicare Modernization Act of 2003. And so it's helpful to know how Medicare is structured, because the way that Part D works is you get, if you are part of original Medicare, you're getting your bills processed by the Centers for Medicare and Medicaid Services. Then you could buy into a standalone prescription drug plan. So you keep the way that you were doing your original Medicare, and then you just buy a plan for prescription drugs. Part D is administered all through private plans. Now with Part C, you would enroll in a Medicare Advantage drug plan. And by far and away, the most common way that you do this is you have a Part C plan that covers A, B, and C for you. So you've enrolled in one plan and they're giving you all of these benefits. And then, so the the standalone prescription drug plans are called PDPs. You'll hear that a lot during this workshop. And then the Medicare Advantage drug plans are known as MAPDs. And this is just a percent of Medicare beneficiaries enrolled in Part D. We just picked 1 month of the year for ease. So this is in June of any given year. You can see the top of the yellow bar is the enrollment. So in 2006, when it was first started, a little over half of Medicare beneficiaries were enrolled. And now we're looking almost at 80% in 2021, which is the most recent year of data that we have right now for Part D. And the yellow and blue bars are the breakdown between people enrolled in MAPD or Medicare Advantage prescription drug plans, and then the yellow is PDP. The people with the green and blue bars are not enrolled in Medicare Part D. The green bar are people that are receiving a retiree drug subsidy. So they're actually they have coverage for their prescription drugs through their employer, who they retired from, but it's not part of Part D. It wouldn't be, something that we would see in the data. And then the blue are just not enrolled. And it looks like, so the retiree drug subsidy is decreasing over time, but that doesn't mean that employers have stopped providing drug coverage. There are different mechanisms that we will talk about later. There are employer group waiver plans, for example, and that will be highlighted in kind of the plan characteristics segment. So stay tuned for that. And then when we're talking about the research files, how researchers will get information about all of these programs, traditionally for fee-for-service or the original Medicare, you buy a set of files. And then if you want information on Part C, that started becoming available in 2015, and you would buy a separate set of files for those two programs. But with Part D, because it's all private drug plans, it's all one. So unless you've specified otherwise, if you request Part D data, you're going to get information on both fee-for-service or original Medicare and Medicare Advantage or Part C. And then, so that's the overview of how it all fits together. The way that the prescription drug program is administered is that it's a competitive model where beneficiaries can voluntarily purchase drug coverage offered by private plans. So the plans are competing for the beneficiaries. They can alter their benefit design or their premiums, how they charge co-payments, and then they're vying for beneficiaries, and plans typically cover a particular geographic area. So that's something to be aware of. When you're a beneficiary, you enroll for a calendar year. So if you turn 65 in June, you have the opportunity to enroll in a Part D plan. If you enroll, then your enrollment for that year ends in December, and you will need to either re-enroll or say, yes, I want to continue for the next year. Beneficiaries can do that anytime between October 15th and December 7th. So that is the open enrollment period, and that's where beneficiaries decide how they want their coverage to work for the following year. There is a late enrollment penalty for those that don't have some other form of prescription drug benefit. So this is, beneficiaries have to pay a premium per month. So they are going to want to maybe avoid that if they, I'm not taking any drugs, I don't need to sign up for this Part D plan. But if they don't, and they don't have any other drug coverage, they can't show that they have some other drug coverage. When they do decide, oh, I better go pick up this coverage because I'm going to need a drug, then they would receive a late enrollment penalty. And it's like 10% of the base premium or something like that. So the number changes every year. The base premium kind of goes up every year. And so your late enrollment penalty could go up every year as well. So that's the incentive for people to enroll right away. When a beneficiary wants to enroll, they can go to this website and type in, this is where I'm from. So depending on where you live, you have access to different plans because they are geographically determined. They say this is the locale that we're serving. And you can also type in drugs that you're taking, and you can compare plans, how they would cover those various drugs. Obviously, you might not know what's gonna happen in the next calendar year, but you can make decisions in that way. And premiums vary by plan, and you can see that on that plan compare. So beneficiaries have to weigh a lot of information as they're making decisions. And the Part D plans on their part have flexibility in how they design their plan. they can design their benefit package in a way that's at least equivalent to the standard benefit package, which we'll talk about in a second. And they can decide how they want to assess, what's their deductible level, what copays are they going to access or include. So when we talk about the standard benefit, this is messy and confusing, and that's kind of how this program is designed. Plans, I should note right away, plans do not have to use this standard benefit. They just have to make sure that what they are using is actuarially equivalent. So it's at least as good or better than this benefit. So the way that this kind of worked is that there are different periods. So you start off at the beginning of the year, and you're going to have to meet a certain limit to meet a deductible. And up until that point, the enrollee pays 100%. If you have health insurance in the United States, that's, you're kind of used to that idea. Then when they hit a certain limit, they get to an initial coverage period where the plan takes over more of the payment, and then the enrollee would pay 25%. And again, plans can decide if they want to use this structure or something else, or a copay model, for example. Once you hit a limit here, then you get into this coverage gap period. Now, coverage gap is in quotes because it's no longer a gap. You can see that the plan is paying some, the manufacturer pays some amount of the brand name drugs, and the enrollee does not have to pay the full amount. This has changed over time, however, and we're often, as researchers, using data from the past. That's how it becomes available to us, is from the past, and we might want to see how, as the benefit structure has changed over time, how has that altered behavior? So it's important to know that different years have different thresholds for these standard benefits, and the coverage gap is something that has changed over time. And we'll talk about that in a minute. And then when people get to this catastrophic phase, then Medicare is actually paying more. The plan is paying a portion, and then the enrollee either pays 5% or they have a copay. So before I talk about what the limits are for each of these phases, I am going to introduce a couple of topics. One is true out-of-pocket spending, or TROOP. The best way to think about these is payments on behalf of the patient. So they could be something that the beneficiary is actually paying themselves, but it could be, a family member is chipping in, or there's a charity that that's helping them out. But also it could include supplemental drug coverage through qualifying state pharmacy assistance programs. Part D's low-income subsidies will count towards the TROOP payments, manufacturer discounts for the brand name drugs in the coverage gap. So it's not necessarily all out of pocket from the patient's own bank account. And then one of the important things to know is that this will determine people's moving from one phase to another. And the CCW does, so the CCW, I will introduce them. They are the Chronic Conditions Warehouse. That's where they create the research files that we use based on, they get the information and then they turn them into files that researchers can use. And they also, sometimes add variables that are helpful for researchers. So one of the things that they do is they will calculate the benefit phase for you. So you can see for any given prescription fill, where was the beneficiary in relation to those phases that we talked about. So good to know that that's kind of behind that. Another thing to know is that there is an extra help program, or it's called the Low Income Subsidy, or LIS. This helps people that don't have enough money to really buy into the Medicare Part D program. It also, prior to the Medicare Part D, people who were receiving Medicaid benefits, for example, could get prescription drug coverage through the state. At that, when Medicare Part D came along, the state said, we really want Medicare to be paying for this, but we will help. We will make sure that people can enroll. And the types of help they get help with premiums, deductibles, coinsurance, and it's a varying level of help depending on how they qualify, what their income level is. There's no coverage gap liability, no late enrollment penalty, and the copay, they get a small copay in the catastrophic phase rather than having to pay a % of the drug if they're in one of these standard plans. There was a major effort on the part of CMS and advocacy groups to get people enrolled into Part D plans through the low income subsidy if they qualified. And so you do find pretty good enrollment. And at the beginning in 2006, when only about half of the beneficiaries were enrolled, a lot of them were low-income subsidy people because of that effort to get people enrolled into the program. And then there are benchmark plans that are available to LIS enrollees, and then they don't have to pay a premium on those. If they choose a different plan, they just might have to pay the difference between the standard premium and what the plan is asking for. So they're not tied to the benchmark plans, but they are available. So going back to our picture of our standard benefit, the deductible phase is pretty standard. It's total drug spending is $505, but that should all basically be troop spending or true out-of-pocket spending. The plans aren't covering anything in that period. But again, plans can change the deductible level. This is just the standard benefit, so plans could make that smaller if they wanted to. To move through the initial coverage period and get to the next phase, the total drug spending needs to equal $4,660. Then when we move through the coverage gap phase, now we're relying on the troop spending. So when the troop spending threshold reaches $7,400, that is when a beneficiary would enter that catastrophic phase, and the breakdown changes again as to who's paying what. So the estimated total drug spending isn't going to be this, or the total drug spending isn't going to be the same for every individual, depending on their particular blend of, are they having generic or brand name coverage? But they, it's about maybe $11,000 total drug spending before coming to the catastrophic phase. So you can imagine some people with really expensive drugs kind of shoot through all of these phases very quickly. Some people kind of move through more slowly. And we can see on the Part D event file kind of how people go through those phases. And Gia will talk about that later. And as I mentioned, the standard benefit structure, those phases haven't changed over time, but who pays what in each phase and what the limits are to go to the next phase have changed over time. So if you're looking back at previous years of data, it's just good to know that people were facing different constraints as they were going through. And then that coverage gap that I mentioned, it's closed now, so that people do get some coverage for both brand and generic in that coverage gap phase. But at 2010, it was 100%, and it has changed over time. The breakdown has changed to the beneficiary having to pay less, and the plan having to pay some, and manufacturers having to pay more in this coverage gap period. Through discounts. And then generic drugs, again, the coverage gap has changed over time. So when we're looking back at older data, just good to note that different years are going to have different setups there. Now, if a beneficiary goes on to that plan compare, on average, the average beneficiary has a choice of nearly 60 plans. However, it depends on where you live. So, if you're in a really rural area, you might not have any Medicare Advantage plans, or very few Medicare Advantage plans that will serve your area. So when you log on to that site, you can type in your zip code and it kind of shows these are the plans serving this area. And then, you might have a choice of standalone PDPs, Medicare Advantage plans, and this kind of breakdown has changed over time. The weighted average Part D premiums have changed over time as well. One thing to point out, so the way that Medicare Advantage plans typically, they are administering drug coverage, but they're also administering A and B. And so they can kind of subsidize the Part D part of their business line with anything that they can make off of A and B. So you will find that the premium portion is lower, but people are paying kind of one premium that will cover A, B, and D. The PDP premiums then tend to look higher than the MAPD Part D portions, but the PDPs are only administering Part D benefits, so they look a little different, but they can, as it shows here, they don't have to have the same deductible as that standard benefit, and in fact, most of them don't. So the average deductible is lower, and especially for Medicare Advantage Part D deductible tends to be lower. One other way that plans have a chance to alter kind of how they compete for beneficiaries is and how they make money is to put different drugs into different tiers. They typically work with pharmacy benefit managers who help them design these formulary tiers. So a particular drug might be a preferred generic for a plan, or it might just fall into the regular generic. They could make it a preferred brand and then have less cost sharing, or they could have a non-preferred drug, which then they would tend to have more cost sharing for to kind of disincentivize people from using those. And then they usually have a specialty tier, and those tend to be drugs that tend to be very expensive, newer drugs. So we have information on the tiers and on the formulary design for these plans in our Part D characteristics files, which we will be talking about later today. So stay tuned for that. So really what we're hoping to do with this workshop is just familiarize you with the Part D program and kind of all the information that you have that will help you do research. So we have demographic information in the MBSF, the Master Beneficiary Summary File. Becky's going to be talking about that in just a minute. We'll be hoping you can become acquainted with how the Part D event file is kind of created for us. We don't spend a lot of time on that, but we try to give you the language that you can use if you need more information. Where might you look? And then we can hope that you can understand what's in that Part D file, the drugs, the costs, all of that, and look at all the Part D characteristics files that are available, formulary files, prescriber information, pharmacy information. And then we're going to be going through, Gia has quite a few applications to show you how she's been using the data. So that will help you understand kind of the challenges that she faced and how she was able to use the data to answer her research questions. And so, and then kind of think about, we do have other Medicare data that's available. It's, Part D data on its own is really interesting, but when you can combine it with other Medicare utilization data, it can be really powerful. So we'll talk about that as well. That is kind of where we are headed. Are there questions? I think I saw some in the chat, and I know some were getting answered. So there was a question about if there's a penalty for delayed enrollment. Why is there a large fraction of beneficiaries with no coverage? And that is because some of them do have creditable coverage. So they are getting Part D, or they're getting their prescription drugs paid for somewhere. Maybe the VA is covering them. As long as they can show that that's the case, they will not face a late enrollment penalty. But we no longer have any information about whether someone has creditable coverage. We just know that they're not covered. So that's one downside. We just see that they're not enrolled. But at least it gives us information on whether we should expect, if we know that someone's not enrolled, we know not to expect any drug events in the Part D data versus are they just not using any prescription drugs. So that's one reason. And there are some people that are just not, maybe they're not savvy about what the late enrollment penalty might mean to them. And then we'll be talking more about how the costs are kind of broken down later on. So hopefully you can stay tuned for that. And I think that is all the questions I see. If I've missed anything, please feel free to, you can put them in the chat during the break or something like that. And I'm going to turn it over to Becky Vick, who will talk about the Master Beneficiary Summary File, which incidentally is the same. It's one enrollment file that you can use for all different types of Medicare data that you might be interested in using. So if you've used it, if you've used, the MBSF in conjunction with A and B data, it's the same file.